Hi, I'm Dr. Heather Herdman, and I am the Chief Executive Officer of NANDA International. I wanted to talk to you a little bit about maybe some tips that might help you as you try to market or sell the NANDA classification. And there's a variety of different audiences for that. So it could be educators or nurse administrators or even electronic health record companies. And each of those may have a different perspective on why a terminology. So first, let's start with the book. Okay. Who would you market the book to? As I see it, there are really two main audiences. One is nursing universities, so both faculty and students. The other is healthcare organizations, both nurse educators, nurse administrators, and your informatics or information technology professionals. So let's talk about those a little bit. In universities, I think one of the most important things to get across to faculty members is that this book is not just the terminology. And when I say that, it's important because this is only the third edition in which we have actually had chapters in the book. When the book initially came out, it was simply the terminology with no pre-matter at all. When we first did chapters, which was 3 editions ago, those chapters were much more about the working of the NANDA International organization and not so much about the terminology or about how to use it in practice. So this is only the 2nd edition in which we've had chapters aimed at nurses and nursing students. And what I know from my own peers is many faculty members don't know that. They see the NANDA book and they think about what they used to know as the NANDA book, and so they think it's just the terminology. And so while they understand why it's important, they go to another author's book because they're looking for those chapters on how to use it that didn't used to exist in the NANDA book. So it's really important for them to understand that our book has introductory chapters that are written with undergraduate nurses in mind. It's also really important to talk about the fact that those chapters have case studies and vignettes in them. This is important because a lot of focus in nursing education in the last few years has been on case studies and vignettes as ways to improve students' clinical reasoning. So that's why they're here. So for faculty members to know that, wow, we have case studies that will actually walk a student from a very basic case up through a very complex case, that can be very helpful for them as teaching material in classroom situations or in simulation labs. The fact that we link the diagnosis to assessment and to the nursing process in general and help students to understand how to accurately diagnose is important as a faculty member. It clearly shows nursing diagnosis as the end result of clinical reasoning and not as simply a documentation tool. Now, that may not make a lot of sense to you, but unfortunately, when nursing diagnosis first hit the scene many years ago, people who didn't understand it very well started to see it as the care plan, which was a paper document that every patient got that had diagnosis, outcome, and intervention. And students used to spend inordinate amount of time every week writing out these care plans by hand to turn in on their patients. And so authors got really savvy and started creating care plan books that students could then sit and copy rather than having to think about the judgment process. It was convenient, but it wasn't really helpful for the profession. Because what it did was it started to make people think that the only reason to have a nursing diagnosis was it was something you had to do for class. And once you became a real nurse, you would never have to use it again. Well, that's not what we want people to think about diagnosis. We really want them to think about it as this is what drives your thinking process. You should be thinking about what is the diagnosis, because that's the only way you can choose interventions that are going to make sense for this patient. Yes, we use it to document, and yes, that's important, but it's not the main reason for nursing diagnosis. The other thing that the book does is it helps students understand the taxonomic structure. And why that's important is that it helps them to identify diagnoses with which they may not be familiar. Or sometimes they'll have a patient who is on an orthopedic unit, and so they're studying orthopedics, but that patient happens to also be diabetic. And one of the most important things, because of the orthopedic surgery that they're going to have, is that blood sugar control, but they haven't gotten to that part of their education yet. So by being able to look for nutrition-related diagnoses, they can find a diagnosis related to that patient's blood glucose stabilization, and it can help them find something that they wouldn't otherwise have already known. So the taxonomic structure is helpful. Another thing that's important, most universities have faculty members who are researchers. And researchers are looking for things that they can be really comfortable saying are up to date, are validated, and are not geographically bound. So we don't want to be teaching something that only works in Canada or only works in the United States. We want something that we can use to talk to our colleagues all over the world. This is an international terminology developed by nurses from around the globe, so that helps. It also allows us to talk about the fact that nursing is different around the world. Some of the diagnoses may not seem appropriate in different geographical locations. And students may ask, well, why do we have this? And it gives us a good opportunity to talk about how the nursing profession, like all professions, differs by regulation, by country, and how nursing is seen in different countries that may be different from our own. It also allows us to maybe challenge that a little bit and wonder, well, wow, if nurses in that country can do this, why can't we? Should we be doing these things? Are these things we should consider? And it allows us to have a conversation about what are the boundaries of the nursing discipline and how might we want to think about that within our own geographical settings. The knowledge that is contained in NANDA is peer-reviewed and it's evidence-based. It is routinely revised, refined, and updated. And every edition, as this one, has numerous changes, has numerous revisions that come about from input of nurses around the globe who are in practice, education, and research. Some of the key changes here. We do have that stronger influence on clinical reasoning and really looking at the understanding of the concepts that underlie the diagnoses of the discipline. So we're not just saying, go make a diagnosis or go pick a diagnostic label. We're really talking about understanding what sleep pattern means, what a normal sleep pattern is, and then looking at the abnormal sleep pattern. We have 17 new diagnoses. We have changes that were made to 11 of the diagnosis labels. 8 diagnoses were retired, and 72 were revised. So there's a significant amount of change in this edition. We changed the definition of health promotion, and that's important for faculty to know because as they're teaching, they need to be sure that they're up to date on what is a health promotion diagnosis and when is it acceptable to use one. So we used to say you couldn't use a health promotion diagnosis unless the patient asked for one, unless the patient really expressed a desire to improve health. We've revised that definition because of some submissions that came in from neonatal nurses. And we realized that that definition was somewhat limiting because we have nonverbal patients of all ages who do have health promotion needs, and nurses do identify those and act on those every day. So we've now changed that definition to say that in individuals who aren't able to verbalize, a nurse can assess that a health promotion possibility exists and can act on the client's behalf. That's important for faculty to know. Equally as important for faculty is to understand the new diagnostic indicator categories that we have developed. We used to have really long lists of related factors, and quite honestly, that was a criticism of the terminology, that it wasn't clinically useful, and that we always said you should intervene on related factors, but some of them you couldn't intervene on. I can't change your age or your ethnicity or your family history, and yet those things were listed in related factors. Similarly, we had diagnosis, medical diagnosis, procedures, treatments, drugs. Again, I cannot independently modify any of those things. But those are really important things for students and nurses to be aware of. They are assessment criteria that we have to know about. They're just not etiologic or related factors in the way that NANDA uses them to direct intervention. So we took a look at those lists and we developed these two new categories: at-risk populations and associated conditions. At-risk populations are the groups of people who share characteristics that cause them to be susceptible to a certain human response. And those are your demographic, your health or family history, growth and development stages, or even exposure to events or experiences. Things that put you at risk, but that we can't do anything about. And then those other things, the associated conditions, are the medical diagnosis, injuries, procedures, treatments, drugs. Again, really important for us to know about and take into consideration, but they're not independently modifiable by professional nurses. But they do support accuracy in diagnosis. So you will now see for almost all of our problem diagnoses, at-risk populations and associated conditions, in addition to the defining characteristics and the related factors. What this has led to, however, is we've gone in some diagnoses from a laundry list of related factors down to maybe one, or even in some cases, none. That's problematic because we have nothing at which to aim our intervention. So over this next cycle, we'll be asking scholars and researchers to help us determine whether or not there truly are related factors. So those etiological conditions that nurses can intervene on independently, and if so, to revise those diagnoses. Or we may decide that some of those diagnoses are in actuality a renaming of a medical diagnosis. And that happened in our history where nurses were kind of a mindset that if we're intervening, if we're doing an intervention, we need a nursing diagnosis to go with that intervention. We don't really feel that way anymore. We know that nurses treat medical diagnoses all the time, both independently and interdependently. So we don't need to rename congestive heart failure. We know nurses treat it. So we can have nursing interventions for both medical diagnosis and nursing interventions. We simply don't need to rename the medical diagnoses. Also for students, it's important to know that we've given several clinical reasoning tips in addition to the case studies and the vignettes. These are kind of helpful ways for students to remember to work through the entire process of clinical reasoning and not to stop early. You know, come up with an idea, oh, there's the diagnosis, and then just rush to treat it. We really want to make sure they go through the process of validating and confirming or refuting a diagnosis. So we've given them some tips to help them to do that. We also compiled a question and answer chapter, and those are really based on questions that actually are emailed in to our offices all the time from students and faculty members alike. We took the ones that are most common and gave some answers to them in the book so that students can flip through and understand what's the difference between a defining characteristic and a related factor. How do I use this? When is this appropriate and when is it not? So we think that that's a really helpful thing for students. Now, when we think about healthcare organizations, here I'm talking about hospitals, home health agencies, nursing homes, public health, all varieties of healthcare organizations. There are really three types of people that we target in those organizations. First is the nurse educator, and that's because we want to encourage them to have a desk reference, have the actual book available for reference on every unit, so that nurses can quickly page through and find something if the computer's busy or maybe their electronic health record system isn't set up in a way that it uses all of the terminology appropriately, so they can go to the source and actually look at the diagnosis. But also so they have those introductory chapters to help them to think about their clinical reasoning. Nursing administrators we target for a different reason. We want them to recognize the wealth of information that can be available in an electronic health record if you implement the terminology correctly. They can use that data that they can mine out of an electronic health record for quality improvement projects. For example, in the United States, and now becoming more commonly worldwide, is the magnet hospital affiliation or status. And to be a magnet hospital requires that nursing research is happening in those facilities. And sometimes hospitals struggle, if they don't have a university affiliation, to figure out, well, what could we study? What kind of research can we do? And it becomes a little intimidating. So to say to them, hey, you have at your fingertips in your electronic health record a wealth of data, and you could start mining that data to figure out, gee, when do patients fall? What are we missing? Are we actually finding patients who are at risk for fall, but we're not diagnosing them? Or are we not treating a certain diagnosis well or at all? And by having the data available in the record, they can start to pull that data and then look at how could they improve on the quality of caring for patients with that data. Finally, nursing informaticists. Bigger hospitals tend to have these. Smaller hospitals may not, but they may have nurses working in the information technology department. And it's really helpful for them to have a copy of the book, or for the IT people to have a copy of the book, because they can look at the terminology and the taxonomic structure and they may get that, but if they don't understand how nurses use it and why it's important for nursing practice, they make sometimes arbitrary decisions that, okay, we'll have the label, but we're not going to include any of this other stuff. And unfortunately, that other stuff, which is the assessment data, is so important to have. So by having them be able to access the book, it allows them to better understand what it is that they're putting into their computers. So that's the book. The other, maybe even more important area is the digital version. The digital version, in my way of thinking about it, is something that can be used, again, by universities and by healthcare organizations. It can also be used by electronic health record vendors, but I'm going to talk about that kind of in concert with those healthcare organizations. Universities can use it both as a test environment for electronic health records, because you're starting to see universities that have electronic health records as part of their clinical practice, or as their case scenarios and in their simulation labs, so that nursing students get used to using an electronic health record. So they will have a test copy of an electronic health record. And then they hope that that helps them to use it better when they go into clinical practice. So having NANDA in those test environments, in those university settings, is really important, because if they learn it well, they will continue to use it in practice and ask for it in practice. So we really want to encourage them to populate those EHR versions with NANDA. Simulation labs are the other kind of up-and-coming place that I'm starting to see NANDA incorporated. We're starting to use simulation labs more and more worldwide, partially because there's so many nursing schools and medical schools and physical therapy schools popping up as healthcare demands increase. There aren't enough clinical placement sites to take care of all those students. So we're starting to substitute some of those hours that used to be done at hospitals or in health centers in simulation labs within the university setting. So we have these really fancy mannequins, and we can program them to have different heart rates and different blood pressures and all kinds of things. But up until recently, we haven't really taken advantage of that assessment data and helping nurses think about their clinical reasoning skills. We've really focused on technical skills. So taking the blood pressure or identifying cardiac arrhythmia, all really important. But when we start to coordinate and have not only them assessing that, but then identifying it in that electronic health record component, they can actually start to link what they're getting from the mannequin to a health assessment, to a diagnosis. So that's a really important component in university settings. In healthcare settings, we're moving to electronic health records at an astounding rate. It seems to me every day we're just adding more and more electronic health records. It's important to recognize nursing is not a revenue-generating department anywhere. And because of that, resources are often tight. And what I hear people saying is, we can't get money for NANDA because nursing doesn't make money. Well, that's true, but nursing saves money, and that's really important. So when I talk to administrators who will say, oh, I can't possibly budget for that, or even IT directors or quality directors, what's really important for them to understand is nursing saves you money by preventing events that should never happen. In the United States, we talk about never events. That's becoming a much more common term worldwide. It can be tied to reimbursement, to insurance. It can be tied to how hospitals are rated internationally, whether or not they are accredited. And that's really important for them to continue providing care for patients. So what we want to make sure that people understand is that by having NANDA in a system, they're able to link excellence in assessment and diagnosis to those patient outcomes that nurses have been proven to affect, and that affect then patient outcomes. This means that we can reduce length of stay, we can reduce readmissions to hospital, we can reduce events from happening, sentinel events that cause significant delay in patient care or even patient death. So we don't generate the revenue, but we certainly can save them revenue. And that's an important point to make, because when you start seeing things such as falls or pressure ulcers, what happens is a quality improvement project gets put into place. And often they're having to try to collect data by hand to figure out what's going on. When in fact, if they had NANDA in their system, all that data would be available to them really fast. So one of the ways that I talk to quality people and nurse administrators is to say to them that one of the faults is when we only focus on the number of falls that a hospital has, or the number of pressure ulcers or pressure injuries that a hospital has. What we miss when we do that is knowing whether or not the nurses had identified that those patients had a risk for falls or a risk for pressure injury. If we know that there are 10 patients on a unit that are at risk for fall and they have no falls, but in another unit there were 25 patients at risk for falls and they had 1 fall, we know that yes, we had a fall, but in the scheme of things, 1 out of 25 potential is pretty darn good. On the flip side, if we see that of those 10 patients who were at risk, 5 fell, but on that same unit with 25, 1 fell, we now have a 50% rate to less than a 5% rate. I want to know what's different about what's going on in those 2 units. By having NANDA data in there, I can tell, did they identify them correctly? Were there more people that were really at risk than were identified on one or the other of those units? And when they identified them, are there certain interventions that are more effective in preventing falls than others? If I only focus on the fall rate, I don't have any of that information. But if I mine the NANDA data, I have that information at my fingertips, and that can make the quality improvement process much faster and much more effective. So those are good reasons. Healthcare organizations, I think you also have to think about, depending on the country you're in or depending on the region you're in, you want to think about system versus setting. Many hospitals and clinics are parts of larger systems. So rather than going into one flagship hospital or one major clinic and trying to get NANDA introduced, think about it on a system level. Communication is one of the most important items in healthcare today. The Institute for Healthcare Improvement, the World Health Organization, all of these major organizations are talking about the fact that it is critically important that you have standardized communication across and within disciplines, so that when a clinic nurse is talking to a hospital nurse, is talking to a hospice nurse, they're all speaking the same language. So if we can license an entire system with the same terminology, they can spread the cost, and more importantly, they can communicate across system in the same way. They understand what they're talking about. It also makes training easier. So if I start off as a nurse in a hospital and I now want to move to the hospice setting or to a home health setting, I already know the terminology. I already know what the documentation is going to be because it's the same. So it makes it easier for me to move from site to site. You want to think state and federal. There are countries and states that have state organizations, state health systems, or federal health systems. And again, rather than going hospital to hospital, if we go federal or we go state, we have, again, a way of spreading cost and making it easier for us to have the same kind of communication across all of the settings that those organizations are responsible for. So we need to consider pricing models that consider systems, states, and federal. I think it will make it easier to market to, and we can really play on the consistency of data across the continuum of care. So I hope that helps. And I'm always available to answer questions if you have any. Thanks.